Hello, everyone. Welcome to today's webinar called SBIRT and Sexual and Gender Minority Youth. I'm Christina Dryman, and I will be the moderator for today's event. This webinar is produced in partnership with the Adolescent SBIRT Project, NORC at the University of Chicago, and the BIG Initiative, and is sponsored by the Conrad N. Hilton Foundation. We have many exciting webinars planned for 2020, including a 4-part series called Using SBIRT to Talk to Adolescents About Substance Use. Register for one or more of these events on our website at sbirt.webs.com/webinars. For your future reference, you can download the PowerPoint slides, handouts, and other resources on our website at sbirt.webs.com/SGM-youth. After this webinar concludes, you will receive a follow-up email from us that contains instructions for watching the on-demand recording and obtaining a free certificate of attendance. If you wish to ask a question, you can do so by typing into the questions pane in your GoToWebinar control panel on your computer or mobile device. After the webinar concludes, we will post answers from the presenter on the webinar's website. So without further ado, let me introduce our expert presenter for today. Dr. Holly Fontenot is an associate professor at Boston College. Her research focuses on the promotion of positive sexual health and prevention of sexually transmitted diseases, with a focus on sexual and gender minority adolescents and young adults. She is also adjunct faculty at the Fenway Institute and a clinician consultant for the Sylvie Rattel STD HIV Prevention Training Center in Boston. So I'll go ahead and hand it over to you, Dr. Fontenot.
Excellent. Thank you, Christina, and good day, everyone. This webinar provides an overview of unique needs and challenges and gender minority youth's experiences, health disparities associated with alcohol and substance use, and strategies for integrating adolescent SBIRT screening, brief intervention, and referral treatment appropriately into care. Today, I'm going to provide a general overview of the main points, and you'll have access to the slide deck and the references at the end. Participants today are going to learn about terminology for sexual and gender minority youth and get an overview of their unique needs. We'll also talk about provision of affirming and culturally competent care, understanding how gender identity and sexual orientation are key factors in understanding patterns of alcohol and substance use and the experiences of health and well-being. And we're going to finally talk about strategies to utilize and adapt the adolescent SBIRT for sexual and gender minority youth. So now I'm going to go ahead and talk about language and how and why clarity in language is very important. So in order to foster health and address the unique medical needs of sexual and gender minorities, it's important first to make sure that we're all on the same page. Having clearly defined language and terminology helps us to better understand the unique needs and experiences of varied subgroups of sexual minorities. It also helps us articulate and measure health disparities locally in our community, in our practice settings, and also nationally through larger scale research projects. And finally, it provides a foundation of understanding in which to build and foster sexual and gender minority culturally competent care and trusting relationships. Sex and gender are often used as terms synonymously and interchangeably, but they're not the same, and we need to understand these differences. Frequently, we describe a child as either male or female based on the child's sex or external anatomy at birth. And we say, you know, this child was assigned female sex at birth, or this child was assigned a male sex at birth. Most people are born clearly male or female, but we have to understand that even external anatomy can fall outside the male-female binary. For example, someone who is intersex may not obviously be either male or female, but would still be a sexed person. Gender identity is something that's different than sex, and it's on its own spectrum. It's more about how we think about ourselves internally. What is our internal sense of self as a gendered person in this world? It's self-identified and a combination of extrinsic environmental factors. What is expected of a boy or a girl, the inherent internal hardwired guidelines. It's an internal experience and understanding of self that develops very early and has a true and clear developmental trajectory. And it's very similar to other developmental trajectories during adolescence. Next, let's shift to think about the ways in which we express our gender. What is masculine or feminine? Or if expression is something in the middle. This is done by the way in which we dress, the language we use, and our mannerisms. It is a fluid and shifting process that's highly culturally determined and can exist separately from sex and gender. We frequently have youth that describe themselves as a gender non-conforming youth. And that means that they have behaviors and expressions that don't line up even with the gender that they ascribe themselves to be. They differ distinctly from the norms of society in general. So now we have gender role, and this is a typical, in the picture, a representation of an old-fashioned idea for gender roles assigned to females. But even this changes over time. Remember Rosie the Riveter? She was a pushback into just this sort of scene after World War II. Gender roles are what we expect to do because of the gender that we are, either chosen or imposed upon us. So these are some very useful terms that we have to get to know. The first is cisgender. And if you think of chemical bonds, cis means on the same side. So the gender identity and sex assigned at birth are the same, whereas transgender means on different sides. So gender identity and sex assigned at birth are not congruent. This is an umbrella term that includes a variety of gender identities that are outside the typical male or female binary. Genderqueer is terminology that is used broadly to describe someone whose identity is not within the traditional binary structure. They have behaviors and expressions of gender that do not necessarily line up one way or another to either male or female. Frequently, this includes the terminology of being non-binary, meaning that their identity doesn't fall or conform to the idea that we think of as an idea of someone who's fully male versus somebody who's fully female. The non-binary person is someone who knows that they do not fit into one category or the other. So gender identity and sexual orientation are not the same. Or even somebody's sexual orientation doesn't have to align at all with their gender identity. All people have a sexual orientation and a gender identity, but there are some people who will say that they're asexual or agendered. And this is something that we always need to keep in the back of our minds. So sexual orientation is how a person is emotionally and sexually attracted to others. Terms describing sexual orientation may include heterosexual or straight, gay, lesbian, bisexual, and queer. These are the most common ways in which people use terminology in order to describe their sexual orientation. So sexuality is a combination of 3 different dimensions. And these circles give you a sense of the intersecting identities, behaviors, and attractions that describe sexuality. So when performing a sexual health history, it's really important to assess for each of these dimensions: attraction, behavior, and identity. This is because these 3 things sometimes do not align. Someone may identify as straight, for example, but engage in both different sex and same-sex behaviors. Attraction is who a person's attracted to. Whether they are the same sex or different sex or gender or any combination of that. Behavior is what kind of sex acts the person is engaged in. Someone can have same-sex behavior but not necessarily identify as gay. An identity is how does an individual person describe their sexual orientation, and what labels or definitions do they attach to it. So now let's shift and discuss health disparities for sexual and gender minority youth, including alcohol and drugs. I'm also going to review some barriers that impact these adolescents' ability to seek appropriate care services. The Youth Risk Behavior Survey is conducted by the CDC Division of Adolescent and School Health, and it gives us a snapshot of health for adolescents in the United States. The age range is high school students, and it's a representative sample of students in grades 9 to 12. The YRBS data are obtained from multiple sources, including national school-based surveys conducted by the CDC, as well as school-based state, territorial, tribal, and large urban school district surveys conducted by education and health agencies. Since 2015, the YRBS has asked about sexual identity and sex of sexual contacts. Some states also ask about transgender identity. This question was piloted first in 2017 in 11 states and 10 large urban school districts, and it's going to be included in the 2019 YRBS optional question list as well. In the 2017 YRBS, 85% of youth identified their sexual identity as heterosexual, 2.4% as gay or lesbian, 8% said that they were bisexual, and about 4% were not sure. Again, as we discussed previously, sexual identity or attraction does not necessarily equal sexual behavior. On the previous slide, we reviewed how youth identify their sexual orientation. Here we review the youth's sexual behaviors. 45% had sexual contact with another youth of the opposite sex only. 1.6% had contact with the same sex only, and 5.3% had contact with both sexes, and 47.8% had not yet had sexual contact. Also, among the youth who did have sexual contact with the same or both sexes, 20.1% identified as heterosexual, 68.4% identified as gay, lesbian, or bisexual, and 11.4% said that they were unsure of their sexual identity. Here we compare some data about alcohol and substance use behaviors. This data compares youth who identify as heterosexual, lesbian, gay, bisexual, and transgender. These data are from the 2017 YRBS and a population-based sample of transgender youth in California. In the 2017 YRBS, analyses based on question ascertaining sexual identity indicated that nationwide, 60.9% of heterosexual students, 72.2% of gay, lesbian, and bisexual students, and 50% of students that were unsure of their sexual identity had ever drunk alcohol. Among female students, the prevalence was highest among lesbian and bisexual students at 74.3%, as compared to heterosexual students at 63.8%. And students who were not sure of their sexual identity, their rate was 50.6%. Among male students, the prevalence again was highest among gay and bisexual students at 66.3%, compared to heterosexual youth at 58.5%, and youth that were unsure of their identity at 47.3%. In this chart, we can see that LGBT and transgender identifying youth have higher rates of alcohol and substance use. 21.6% of LGBT youth tried alcohol before the age of 13. 37.4% currently drink alcohol. 17% binge drink in the past 30 days. And binge drinking is having 4 or more drinks of alcohol in a row if you're female, and 5 or more drinks of alcohol in a row if you're male. 30% currently use marijuana, and that's marijuana use 1 or more times in the past 30 days. And these youth also had higher rates of ever using cocaine, inhalants, methamphetamines, or opioids compared to heterosexual youth. The data we could find documenting alcohol and substance use in a sample of transgender youth also highlighted serious disparities. Over half reported currently drinking, over a quarter reported binge drinking, and nearly 30% reported marijuana use. This is the 2017 YRBS data showing percent of high school students who drank alcohol or used drugs before the last sexual intercourse. This is youth who reported current sexual activity, and that sexual activity in the past 30 days prior to the survey. First, we see a pattern of alcohol or substance use prior to sexual intercourse for those who identify their sexuality as either heterosexual, gay, lesbian, or bisexual, or not sure of their sexual identity. Overall, the rate of alcohol or substance use is higher for those who identify as gay, lesbian, or bisexual as compared to heterosexual students, and highest among students who are unsure of their sexual identity. Similarly, when looking at sexual behavior, students who engage in sex with a person of the same sex or both sexes have higher rates of alcohol or substance use during sexual intercourse as compared to students who only engage in sexual intercourse with persons of the opposite sex. The takeaway I really want you to have from this is that this highlights the importance of assessing both sexual identity and sexual behaviors as part of any health history, and in particular when assessing for alcohol and drug use with adolescents. Youth that identify as a sexual minority or engage in same-sex sexual behaviors are at greater risk of alcohol and substance use. This also impacts risks for sexually transmitted infections, which are also disproportionately high for sexual minority adolescents. So as you provide care for sexual and gender minority youth, it's important to understand the health disparities related to alcohol and substance use and sexually transmitted infections, and how one impacts the other. Assessments of behavior need to be open, non-judgmental, and affirming of sexual and gender minority status. Otherwise, youth will not engage and disparities will persist. So next, we want to talk about our role as health providers and what we can do. It's important as health providers to understand how experienced stigma affects our health. Stigma is an abundantly clear problem for sexual and gender minority youth, more so than for people who identify as heterosexual or cisgender. These youth experience discrimination and homophobia and have concerns related to confidentiality, fears of losing family or friends, or fear of talking about their sexual behaviors. Experiences of stigma and discrimination and increase the risk of physical, social, and emotional health problems. But what's important to recognize too is that despite the fact that many of these kids have more experienced stigma and discrimination, most youth are healthy. This suggests resiliency, coping, and positive adaptation to a very difficult adolescent developmental time. Protective factors for youth may include family acceptance, openly gay role models, and supportive clubs and schools. And providers can help youth by seeking to normalize conversations about sexual health, sexuality, responsible sexual behaviors, and alcohol and substance use. We also can support healthy individual attitudes and behavior choices and encourage role modeling and openness and inclusivity. So general practice is an appropriate place to discuss both alcohol and drug use as well as sexual health. Patients actually desire healthcare providers to initiate these discussions. For health providers to meet the expectations of patients, they do need then better and ongoing training to support knowledge about alcohol and substance use and abuse and sexual and gender minority health, and how using substances before and during sex impacts sexually transmitted infection risk and sexual health. They need to develop confidence and skills to address and treat particular health needs as they come up and do that routinely and effectively and not as an outlier or intrusive idea. Part of this approach would be to be sure that alcohol and substance use screening co-occurs with comprehensive sexual history taking, and that is inclusive and affirming for sexual and gender minority adolescents. This screening and sexual health history is a normal part of any healthcare assessment. That in of itself will improve patient understanding about risk reduction strategies, preventative services, STD testing, and substance use counseling. So to make sure that we meet these goals as practitioners, we need to look at the things that we're doing as individuals, plus how things are structured in our clinics and organizations as a whole. We need to be aware of the particular stigma, challenges, and stressors that our patients have, and the barriers that may keep youth from asking appropriate questions. We need to understand for youth what the coming out process is and how that can impact health. What health and social support information do they have, and where do they get it? We need to collect more sexual orientation and gender identity data. This data many times is called Soji Data, S-O-G-I data, and to have greater understanding of the impact of health disparities, including health disparities associated with alcohol and drugs. We need to make sure that we have sincere and well-developed policies on confidentiality, consent, and privacy, above and beyond simply telling a patient that what we say is confidential and private. We need to be able to exercise this across the spectrum of services that we provide. And lastly, we need to have significant resources available for youth. We have to be prepared ahead of time to guide youth to resources that are safe and accurate. So we need to understand that the barriers to care that all adolescents, including sexual and gender minority adolescent youth, confront when trying to get safe and effective healthcare. Part of it is how do they even get to us? We need to look at transportation, hours of operation, and cost. These are all known barriers for any adolescent. There are also major concerns related to confidentiality. These concerns related to the explanation of benefits, which these may get sent home to a parent. Is it safe for a child if the parent knows that they're accessing healthcare or even sexual health resources? Healthcare literacy also becomes part of our role as clinicians and organizations. There are issues about youth actually knowing what is healthy and what is safe and teaching them about how to use the healthcare system. Coming through the door, youth need to know that's a safe place, a place for them. This means that our interactions with them as providers need to address sexual and gender minority identities, behaviors, relationships routinely, comfortably, and safely from the get-go. Outness and coming out, whether it be in terms of gender identity or sexual orientation, occurs at the same time that youth are individuating themselves from others, finding their peer group, and figuring out how to exist both within and outside of their families. When youth do come out, they often do so selectively to safe persons. They might not come out to you as a health provider because they do not perceive safety in that situation, similar to issues with perceived confidentiality. If a patient isn't out to you, they may not be comfortable answering questions about their specific health behaviors and risks. Because of this, you may not be able to make the right recommendations for care for them. Unknown status means that you're not necessarily providing the best care. When thinking about mental health supports for a child, understanding the degree to which you are out to family or friends is important because it can lead you to what resources you might build and connect them to. A child might be out to friends at school, but not to family. They may be out to you, but not the front desk. So the degrees of outness are things that a child gets to decide within the framework that they feel safe and supportive in. Let's see. So this slide shows you examples of how to use correct pronouns for your patients. This is really helpful when you're thinking about patients that are falling outside the gender binary. So somebody that's transgender or gender nonconforming. It's helpful for you to think about this for yourself ahead of time, as well as to share this with other staff and professionals. Using correct pronouns is an excellent way to demonstrate inclusive and transgender affirming environments. It's also important to use pronouns when introducing yourself to your patients. For example, as I walk into the room, I might say, hello, my name is Holly. My pronouns are she, her, hers. I'm the nurse practitioner caring for you today. Some clinics have little buttons that say my pronouns are. That can be an easy signal of inclusive and affirming care that you're a safe provider. I also want to point out that some people might use the pronoun not listed here. There are some patients that go by the Z, like the letter Z. For example, you might say Dana is in the waiting room or Z is in the waiting room. Z is a gender neutral pronoun. It's the same as they, and many young people use the pronoun they instead of he or she. So, as we've discussed, concerns about confidentiality have been identified as a major barrier. And what you can do is work with your health center to ensure, as appropriate, that confidentiality of an adolescent care is protected in the best way possible. Strategies you can consider are working with your technology officer to create ways to chart confidentiality in the electronic medical record, to make sure confidential records and labs are not posted on patient portals that caregivers manage, and to consider working with the clinic management to understand ways to bill that maintain confidentiality. So know too your state policies for minors to consent for their own medical care. All 50 states and the District of Columbia allow minors to consent for their own STD health services. No state requires providers to notify parents for minors for obtaining these STD services. However, some states do allow or authorize parent notification. So every aspect of a patient's experience, from you opening the door and walking up to the front desk and having your vital signs taken to meeting you and their exit, needs to be recognized and appreciate the differences for anybody's identities. When working with sexual and gender minority youth, we may make mistakes. It's important to simply apologize and say, oh, I'm sorry, I didn't mean to disrespect you. How might you like me to refer to you? What pronouns would you like me to use? What preferred name should we put in the chart? Thoughtful apologies go a long way to change a patient's experience. We have to remember that there's a history of discrimination within and outside the healthcare setting. And that experience is going to flavor any particular patient's experience even before they walk in the door, before they meet us. So as part of providing affirming care, it's looking at our environment that we build around us. Assess your practice and system for environmental cues for safety and acceptance. This here is an example of a poster which can, in a small way, just make very clear that this is a safe place for sexual and gender minority youth. And I briefly talked about collecting Soji data before. Again, that's sexual orientation and gender identity data. And it's very important. Here's a highlighted question that you can use on your intake form if you don't already have a question like this. Youth may or may not identify themselves as sexual or gender minorities on an intake form, so it's important to also ask this question in the privacy of the exam room. Collecting this data will improve quality of care given to minority patients by allowing health centers to measure and track outcomes. It's important to ask these questions every time someone comes in for an annual exam because these can change over time. So healthcare providers can reach out and build partnerships with schools and other youth workers. You can work to set up linkages for referrals and resources for alcohol and drug use as well as sexual health. It depends on your geography. Some urban and suburban schools may have gay-straight alliances and others may not. Many kids find safe spaces in these environments if they are available. Larger urban areas often have LGBTQ youth drop-in centers or organizations and groups called PFLAG. PFLAG is Parents and Friends of Lesbians and Gays, and that exists nationally as an organization for friends and families and caretakers. The CDC link on the slide will give you access to a good number of programs and resources similar to what we've already discussed. So building partnerships with parents is also really important, and as well as skills in communicating with parents or adult caregivers. It's always tricky talking to parents about alcohol and drugs and sex. And now we're asking you to also talk about your identity, sexual orientation, sexual behaviors. For many parents, especially those with preteens, this may be the first time someone's asked them to think about their child's gender or sexual orientation. And many health providers have training and experience working with families, but for some providers, this can all be quite new. You'll need to learn to work with parents to help them communicate with their adolescent. Explain the positive protective influence of open communication may have with their child. During the clinical encounter, spend time with the adolescent alone as well. You want to discover their level of communication that they may have with a trusted adult. Ask them how you might be able to foster that communication or provide them additional resources for support. We know from studies that conducted in the Southwest US that when support and engaged families make space to recognize and confirm their children's gender identity and or sexual orientation, those children have improved school outcomes and completion, and also delay the first sexual debut, and then also see less smoking and alcohol use and decreased levels of self-harm. Be sure to check out the resources listed here as they can help you build these communication skills. This is another resource to provide to parents. You can access this and read it fully by checking out the link that's on the slide. This just shows you briefly what the resource looks like. I know you can't really read it, but I wanted you to see it. You can see how it gives information for each larger heading, and the larger headings are prepare yourself, prepare your teen, work with your teen's provider, et cetera, et cetera. And this is a great resource for parents. So now let's shift gears and review some skills on implementing SBIRT into our patient care. We'll review skills for open, positive, substance, and sexual health communication in particular. These key points in ensuring productive conversations with youth about sensitive topics like sexual health and substance use. First, I will assess my own comfort in how I discuss the topic with the youth, and I'm going to identify any biases I may have personally. Then I'm going to make sure that as my patient comes in, I'm making them feel comfortable, and that I'm using inclusive and neutral language. And I ask all of my questions in a non-judgmental manner. I'm also going to try to make sure that I'm not making assumptions about people, and that I'm not just going to predetermine or guess if they're heterosexual or if they're cisgender. Lastly, I'm also not going to react overtly. Even if I feel uncomfortable or embarrassed by the conversation or the direction in which it's going, I'm going to pay attention to my body language and my posture. When I collect sexual orientation and gender information from my patients, I ask their preferred pronouns and names. I also discuss preferred medical terminology with patients who identify as transgender. Some patients that are transgender don't want to use the terms that are what we consider as health providers just the normal biologic terms like vagina. Even if somebody still has a cervix or a uterus, they may want to call those organs something else, something more neutral. And you can ask them whatever they want to call it, and that's fine. I'm going to rephrase questions or briefly explain why I ask about sensitive questions. If I sense that a patient seems reluctant to answer or uncomfortable about why I might be asking about their risk behaviors, then I just rephrase. I seek to normalize the topics I'm discussing and help youth understand why I'm asking these questions. I will clarify language with patients if they're using terms they might not be aware of so that we can be on the same page and avoid any confusion. So it's time to wake up a little bit, everybody. This is the time for the first audience polling question. Please select an answer on your screen to the question, what is your level of comfort in discussing sexual health behaviors with sexual and gender minority youth? You can select one of the following answers: very uncomfortable, uncomfortable, neutral, comfortable, very comfortable. I'm just going to give you a few seconds to make your selection, and then we're going to look at the results together. Okay, so you know what, this is a wide range of people in the audience. It's always nice to see, you know, we can assess where we feel like that we are, and then it helps us think about ways in which that we might build our skills and our comfort. So we've got actually a pretty great people from, you know, majority people are neutral to very comfortable. So excellent job. Okay. So this is going to help you with that. So thinking about how we collect our sexual health histories. The CDC has produced a great document that helps providers learn about how to ask sexual health history questions. This is the CDC easy to remember 5 Ps. It's partners, practices, protection from STDs, past history of STDs, and prevention of pregnancy. This is a great resource, but it's also important to make sure that we consider how to adapt these questions based on a patient's sexual orientation, behaviors, attraction, and identity. You can find the entire resource document for this on the CDC website, and I gave you guys the link on the slide. So these questions are guided by the 5 Ps, but I've adapted them. So I say, tell me about your sexual partners. Do you know how they identify their sexual orientation or gender? Do you know about your partner's past or other sexual activities? What type of sexual contact or sexual practices do you have? It's important to ask about all different types of sexual practices. If I had already clarified language with a transgender patient for how they like to talk about their body parts, then I would use those terms in this conversation. Also, for men who have sex with men, I ask about receptive and/or insertive sexual practices. It's important to always ask about if they use drugs or alcohol before or during sexual activity too, and I had that highlighted red on that slide. Other questions adapted from the 5 Bs could be, do you and your partner use any protection against STDs? If yes or no, I want to find out what works or doesn't work for them and reasons for that. It's also important to understand how often people use this protection. You can't assume that a person uses condoms with one partner, that they're using condoms with all of their partners. You want to uncover who they're using protection with and why and how. You also want to understand if a patient's using alcohol and drugs prior to sex, and if yes, or during, prior to or during sex. And if yes, then how does that substance use affect their ability to negotiate safe sex behaviors or to engage in safe sex behaviors? It's important to ask if they've ever been tested for HIV or other STDs and what those results are. It's also important to ask if they or their partners have a need for contraception to avoid a pregnancy. Some may assume that gay and lesbian youth are not at risk for unwanted pregnancy. In fact, though, in some studies, lesbian and bisexual females report higher rates of unwanted pregnancy. And this is a reminder for the importance of asking about sexual behaviors and not assuming behaviors related to sexual orientation. It's important too, though, when you're assessing for unwanted pregnancy in lesbian women, that they're not feeling like you're assuming they're heterosexual. You can acknowledge their lesbian status, but just double check that there's anything for them or their partners that they might need to talk about contraception for any reason. So, okay, hold on a second. Just want to slide back here for a minute. Looks like I jumped forward a little too much, but we're just going to head back. All right. Okay, there we go. Okay, so this is our second reflective polling question. Please select, just like before, what was your the different question, what's your level of comfort in discussing alcohol and substance use behaviors with sexual and gender minority youth? Same as last time, you mark 1 to 5 on the Likert scale. And again, I'm going to give you a few seconds to make your selection, and then we'll look at the results. Okay, great. So this audience looks like that they have more comfort talking about alcohol and substance use rather than talking about sex. And that's pretty typical and good though, you know, because that's important that we feel comfortable talking about alcohol and drugs. So we're going to get right into the SBIRT model here. And SBIRT is a comprehensive, integrated public health approach to delivery of early intervention and treatment services for persons with substance abuse disorders, as well as those who are at risk for developing these disorders. From a public health perspective, the goal of SBIRT is to improve the health of a community by reducing the prevalence of adverse consequences of substance misuse, including but not limited to diagnosable abuse or dependence through coordination of early intervention and referral to specialized treatments. And we have 3 components, and that's screening, intervention, and referral to treatment. And on the slide, again, I always try to provide a link where you can get more information. So these are the overall aims of SBIRT. It's to increase early identification of substance problems, build awareness and educate adolescents and about guidelines for low-risk drinking and risk associated with substance use, motivate those at risk to reduce unhealthy risk use and adopt health-promoting behaviors, to motivate individuals to seek health and increase access to care for those with a substance use disorder, and link adolescents that are at high risk for more intensive treatment, and foster a continuum of care by integrating prevention and intervention and treatment into services. Hold on a second, I'm just going to advance the slide. Yep, here we go. So there are a number of screening tools. Yeah, I clicked and then it went back. Sorry. Hold on a minute.
Seems to be just a bit of a delay. Just hang for a second.
Yeah, takes a second. Thank you. So this table just gives you like an overview of common screening tools, and these are numerous and they're available. Many of them are free, and you can click on those and find out more about them as you go. And let's see, hold on. It just jumps around a little bit. I'm going to go one more slide. Here we go. Okay, so So there are different schools of thought about how to conceptualize and define risk. Regardless of which school you adhere, it's important to understand how risk may play into an adolescent's use. And the Academy of Pediatrics has identified 4 general patterns of substance use risk based on the CRAFT screening tool, and that was one of the ones on the table. And they have low risk, which is adolescents who report no use of tobacco, alcohol, or other drugs. And they report also that they've not ridden a car with a driver that's been using alcohol or drugs. Then there's driving risk, which is adolescents who report driving after alcohol or drug use, or riding in a car with a driver who's been using drugs or alcohol. Moderate risk is adolescents who have begun using alcohol or drugs. and high risk is adolescents who use alcohol and drugs. So the CRAFT is a screening tool for alcohol and drug use that's intended for patients under the age of 21. It asks, during the past 12 months, on how many days did you drink more than a few sips of beer, wine, or any drink containing alcohol, use marijuana or synthetic marijuana, or use anything else to get high? Depending on the answers in Part A, then you will ask these questions. Have you ever ridden in a car driven by somebody, including yourself, who was high or been using alcohol or drugs? Do you ever use alcohol or drugs to relax? Do you ever use alcohol or drugs alone? Do you ever forget things that you did when you're using? Do your family or friends ever tell you that you should cut down on drinking or using drugs? And have you ever gotten into trouble while you're using alcohol or drugs? Then you show your patient their score and then discuss the level of risk that they have for substance use disorder. And on this slide, there's a link again where you can get more information about the CRAFT tool. After you do that, in step 2, then you can use these talking points for a brief counseling session. And it's important to learn to use motivational interviewing strategies as part of conducting brief interventions. Specifically, you want to assess readiness to change. Ask open-ended questions, affirm the patient, utilize reflective listening, summarize the patient's thoughts and feelings, elicit a conversation about change behaviors, ask permission and give advice, help them generate options, and also you need to manage if they're giving you any pushback. Here's an example of another screening tool, the Audit C. The Audit C was developed by the World Health Organization and is used to detect hazardous and harmful use as well as identify potentially alcohol dependence. It's slightly longer than the CRAFT, and here you can see the first 3 questions, and these questions ask about quantity and frequency, and there are more questions not depicted that ask about dependence and harmful use. Again, I provided links where you can go and learn more. And here's the one last example. It's the drug abuse screening test. This also is a 10-item screening tool. And what you notice on this item and this survey and all the others is that all questions on all these screening tools are pretty general, which is excellent. They all use inclusive language that's relevant for all adolescents, including sexual and gender minority adolescents. What the questionnaires do not assess for is associated risks related to sexual health. And these risks are very important to consider for all youth, but especially for sexual and gender minority youth. The associated risks with alcohol and drug use include, but are not limited to, increased risk for sexually transmitted infections, HIV, unwanted or unplanned pregnancy, and violence, including sexual violence. I like this pocket card for screening for substance use, and it's very useful. What you can see here is that it does highlight the potential consequences of alcohol and drug use for adolescents. And this pocket card then, if you pull it out and use it during your screening, serves as a great reminder for providers to discuss associated risks, including injury, difficulties in school, driving while under the influence, violence, STDs, pregnancy, and more. This is the back side of the same pocket card, and this reviews the steps for the brief intervention, including raising the subject, providing feedback, enhancing motivation, and negotiating and giving advice. So brief intervention is a behavior change strategy that is a short duration and that is aimed at helping a person reduce or stop a problematic behavior. Motivational interviewing is a method of communicating that's focused on an adolescent's concerns and perspectives and works to enhance their internal desire or willingness or ability to change by exploring and resolving coexisting and opposing feelings about making a change. Reflective listening is important in establishing rapport. You respond to the adolescent with a statement that reflects what the adolescent has said, and it demonstrates that you're listening, and it provides opportunities for you to have clarity with each other. As we discussed earlier, the great importance of providing affirming care related to youth's identified sexual orientation and gender identity. In general, though, affirming care is important for all youth, and providing affirming care is needed when having conversations about any sensitive or difficult topic. Affirming recognizes the adolescent's strengths and accomplishments and makes the statements of appreciation and understanding. Affirming is a strength-based approach to support self-efficacy, which is their self-confidence that change is achievable. Affirming makes it more likely that they'll recognize their own capacity to discuss difficult topics and appreciate their ability to alter them. So after screening, and if problematic behavior is identified, a brief intervention is needed. Immediately following the screening and follow-up, and including follow-up within a few days or weeks, providers should continue to engage with the adolescent. Need to provide feedback about the screen, compare the adolescent scores to national averages or peer populations, discuss concerns about potential consequences of substance abuse, discuss pros and cons of use, negotiate goals, and make a commitment to action. This table shows the steps and elements of the brief negotiated interview. Remember, as you work through these steps, it's always important to reinforce and accentuate the adolescent's strengths and acknowledge the positive in the adolescent's intentions and actions. Affirming the adolescent increases openness of the conversation. This is similar to what we discussed, and the steps include engagement, exploring pros and cons of the behavior using reflective listening, providing feedback, assessing readiness to change, negotiating an action plan, and lastly, summarizing the conversation, action plan, plan for follow-up, providing educational handouts, and thanking the adolescent. Again, there's a link at the bottom of the slide where you can learn more. So now let's shift and think about some strategies. Hold on. Yeah. Let's think about strategies to utilize and adapt the adolescent SBIRT for sexual and gender minority youth. I'm only going to suggest a few minor modifications to make sure that we're all on the same page. It's important to note that sexual and gender minority youth are also at risk for depression, suicide, interpersonal violence, bullying, and all these factors may influence and be related to alcohol use and drugs. Providers can remember to screen for and continue to adapt their comprehensive histories accordingly. But suggestions today for adapting the SBIRT for sexual and gender minority youth focus on sexual risk behaviors and prevention of HIV and STDs. So I always start a conversation with having the adolescent tell them about themselves, like, who are you? What do you like to do? Tell me about your friends, your schools, your hobby. And then I always start with universal statements. And these two quotes here are perfect examples of universal statements that just sort of open conversations and provide a youth an opportunity to engage. So it's important to establish confidentiality for all adolescents like we discussed, but it's important to remember that sexual and gender minority adolescents may or may not have disclosed their sexual orientation or gender identity to adult caregivers. Disclosure can put some kids at risk for homelessness, isolation, or violence. And also discussed earlier, youth will disclose to a few trusted individuals first, and we don't want to break that trust. I start conversations with a discussion of confidentiality and its limits, and explain how we'll strive to keep follow-up visits confidential, but I also clarify risks of releasing medical records and discuss procedures that may break or inadvertently break confidentiality. So on the next two slides, I make some additional suggestions, questions for your assessments related to drugs and alcohol. As reviewed earlier, you can use any screening tool and all of them are great. But here's some additional questions you can consider. Do you go to the clubs or parties where people are using drugs? Does your condom use or other safer sex strategies change when you're drinking or using drugs? Do you feel like the types of sex you have change when you're drinking or using drugs? And here are some ideas for additional questions during a brief intervention. Would you like to think about ways to have fun without drinking or using drugs? Do you have friends that don't drink or use drugs that you could spend time with? Would you be interested in talking about strategies to use or increase condom use while you're working on reducing your drinking or using drugs? Would you be interested in talking about STI and HIV testing, HPV vaccination, or starting HIV pre-exposure prophylactic medications as a way to protect your health? It's important to have open discussions about alcohol and drug use influence sexual risk behaviors like we've talked about. So when to refer, a very small number of adolescents will require the level of intensity or treatment beyond what you'll be able to provide. But how you broach and discuss referral contributes to the likelihood of successful treatment. In contrast to adults, adolescents are less likely to feel that they need help or seek treatment on their own. So in summary, SBIRT has it's been effectively combined with other population-based health services in numerous settings, as we've indicated. Sexual and gender minority youth experience higher rates of substance use and behaviors as compared to heterosexual and cisgender youth. An integrative prevention strategy is an effective and efficient way to screen at-risk youth for substance use behaviors and associated sexual risk behaviors. These in the table are some ideas for settings in which to integrate SBIRT programs. Here I wanted to provide for you a list of other possible screening tools that may be useful in practice when working with adolescents. It's important to screen for co-occurring mental health problems like suicide, depression, anxiety, PTSD, and attention deficit disorders. And it's also important to screen for violence and physical or emotional abuse. Lastly, these are educational resources for healthcare providers, so you can go and learn more about health for sexual and gender minority persons and sexual health, including how to perform a comprehensive sexual health history. These are all very helpful websites for you to go to and learn more about what we've talked about today. And of course, you have the slides that we've provided as well. So I just wanted to thank you for joining me for this presentation, and you have my email address if you need to contact me with additional questions, plus you can just type them in like Christina mentioned in the beginning. And with that, I can hand it back to Christina for us to close down.
Thank you so much, Dr. Fontenot. That was very informative. And thank you for everyone for participating in this webinar with us today. In our last few moments together, let me just remind you that you can download the PowerPoint slides and other resources on our website at sbirt.webs.com/SGM-youth. You will receive a follow-up email from us after this webinar that contains instructions for watching the on-demand recording and obtaining a free certificate of attendance. If you have any questions about SBIRT implementation, evaluation, or training, you can schedule a free telephonic technical assistance session with Dr. Tracy McPherson by emailing her at the address on your screen. So with that, I will conclude today's webinar. I hope you all have a wonderful day. Thank you for joining.